I've given a lot of the same talk for many years, or slight variations on the same talk, talking about 3D echo as a technology and where the images come from, with a few clinical applications. But this year, I was involved in an educational effort by the American Society of Echo, and this was to create an educational DVD on interventional echo. So a bunch of us went to Dallas, and we sat in a hotel room for 2 very dark days on a beautiful weekend and created this DVD. So it's now out. There's a copy of it in the Echo Lab. You can all look at it. But I thought today we'll just go through really some cases that are from that DVD that highlight not necessarily how to make a 3D image, but how to optimize it for clinical questions, and particularly the kind of stuff we do in the interventional lab. So I have four different cases to go through. They're somewhat detailed, and we'll just go through as many as we can get through. It's a small group, so it's a friendly room. Ask questions, interrupt. If I assume you know something and you don't, now is the time to just shout out what your question is. So we'll start with a MitraClip case. All right, so here's the story. 89-year-old male referred for progressive dyspnea at rest. He's got coronary history, prior cab with a sternotomy 20 years earlier, mitral valve prolapse followed by his local cardiologist for many years. He lives alone. He'd been independent in all of his daily activities until about 3 months ago. And then he had to move in with his daughter. He became less and less independent, needing more and more help for activities. And these are a couple of echo clips. So TEs, obviously, using the X-plane feature of a 3D probe. This basically is X-plane, 4-chamber view, mid-esophageal. So that's what all that means, just sort of give you a landmark of how we got the image. And then this isn't just another X-plane mid-esophageal view, so just different angulations. So we often call this the 4-chamber view, the 2-chamber view, the bicommissural view over here, or roughly the 60-degree view. And then on TE, this is typically somewhere between 120 and 140 degrees. So have a good look at those images. So I could be asking you some anatomic questions. All right, so this is the color. Again, the 4-chamber mid-esophageal and a 2-chamber view. Sorry, this is a 60-degree and a 2-chamber. And this is the left upper pulmonary vein. So we'll go kind of quickly through these and then ask some questions. Okay, so first question for the back row is the mechanism and severity of the MR is 4 choices. So is this a P2 prolapse with moderate MR? Is this P2 prolapse with severe MR? Is this P3 prolapse with severe MR? Or is it a posterior leaflet perforation with severe MR?
Can we see the pictures again?
You want to see the pictures again? Okay, all right, that's a good answer. I'll show you the color. What do you think?
P2 severe.
Okay, we'll jump to severity. So, okay, severity, 2 choices, moderate or severe?
Severe.
Severe. What makes you say severe?
It is,
So I guess what are the features that are present? Because you don't have all the data, right? You don't have every metric that we might use to qualify severity, but you have you only have 2 things. You have color and you have pulse wave Doppler. And I guess you have an anatomic image in the previous slide that had no color. So I don't know if I can pause this. I probably won't get it right. Oh, yeah, there we go.
yeah, because it
That's actually not bad.
Eccentric.
So look at that vena contracta,
Yeah.
right? This is, there's no baseline shift, so it's hard to do at PISA. The angulation of this flow is almost perpendicular to the axis of interrogation, so a flow convergence would be pretty tough for a PISA calculation. But the value you do have here is a vena contracta. So the narrowest portion of the proximal part of this jet is, well, let's see, that's our 1 centimeter marker. That's somewhere around 8 millimeters, ballpark. Okay, so what would be considered severe MR from a vena contracta perspective?
Vena contracta. Okay.
Anybody know the number? 0.7. So more than 7 millimeters in thickness is consistent with severe. This is easily more than 7. So we have a vena contracta that would suggest severe. And this data over here, we have systolic flow reversal in the pulmonary vein. So that's a pretty specific finding for severe. Okay, so we're going to say this is severe MR. But what about mechanism? That's actually, I think, the more difficult element. I'll go back to these images again. Okay, do you see it in this view here? Can you tell from these images here the mechanism? All right, so this is anterior leaflet, posterior leaflet. This one, it's kind of hard to say sometimes. This one over here, this is really weird over here, right? So this is probably your bicommissural view. So typically in this view, the middle scallop is P2. This one is somewhere off to the edge. And if you look over here, you've got your anterior leaflet is the one that runs down from the aortic valve. So this is your anterior leaflet. And the one that's opposite that is your posterior leaflet. This can be a little tricky. If you angulate the TE probe a little bit, you can actually scan through P1, P2, or P3. So you kind of have to put it together. So this image tells you it's a very lateral scallop. It's way out here. And this one tells you you're not seeing it perfectly when you see A2, so it's probably going to be P1 or P3. That's kind of how you go through trying to figure out the anatomy. What's going to be very helpful is when we do 3D. It'll be obvious, hopefully, once we do 3D. All right, so the questions, these were the questions. If you said P2 prolapse with moderate MR, I would say no. So it looks like it's the posterior element of P3. Color Doppler predicts a very large flow convergence with flow reversal, just as we talked about. With P2, same reason, the severity is correct, but the anatomic localization is wrong. Congratulations, if somebody said P3 was severe MR, for the same reasons. And then if you look at the 3D, hopefully it gets a little clearer. So this is how we use a 3D echo on a TE. So we're looking straight down on the mitral valve. It's immediately oriented to put the aortic valve at 12 o'clock. And that's, I've emphasized to all the fellows and any sonographers who are in the room when we do these interventions, it's very important to have a standard representation of how you show things, otherwise you get lost. Jeff?
That's not something that you just manipulate that on the wheel, right? Because I never control the ball that moves that.
So there's two ways to do it on the Philips machine. It's not the acquisition. You do the acquisition, and it never looks like this. It usually shows it from the side. Okay. So the movements are you acquire it, you take the little ball, you roll it down, which flips the image up en face, and then you can either use the ball and rotate it around, or there's a little button called the Z button, which is the Z plane. It's only on the newest IE33s, the Z plane. So like I think on Earth it's missing, but on Sparkle it's present, so that's why we usually use Sparkle for interventions. So the motions I do is you capture, you rotate it down, you dial the Z, and it spins it to put the aortic valve at the top. And that's it. That's the only manipulation that's required. The only other thing you can do is play with the gain. And I'll show you the importance of gain. But this is a pretty standard acquisition. It doesn't come with the labels, but once you've stuck aortic valve at 12 o'clock, then it's always going to be, basically you move lateral over here to medial, and you just go 1, 2, 3, moving lateral to medial. So this is the atrial septum near P3, and the left atrial appendage exists over here around 10 o'clock. So if you think of the aortic valve as 12, the commissures tend to be roughly from 3 to 9, and the LA appendage is going to be over here at 10. So those are your landmarks. And if you look at P1, it looks pretty normal. P2 looks pretty normal. P3, it's kind of hard to see while it's moving, so you do a still. And here you see P3. It's a focal prolapse of P3. Now when you've got that sort of, you think you know what's going on, now you can get a little funky and rotate around and manipulate in non-standard views. But the first thing is you have to understand the standard view first, and then you can ask more details. So over here, if you look at this, all I've done is you've rotated the data set around a little bit, and now the little arrow shows we're looking straight at P3 from the side. And you can actually see it's pretty small here. But there's actually a circular defect right here, and that's the anatomic hole. So the aortic valve is here. We've rotated. So we're sort of looking like this now at this little prolapse section. So it's a pretty distinct P3 flail, actually. Any questions about that? Okay, so that's kind of how we quickly manipulate a 3D data set to get the anatomic information and the standard Doppler stuff to get the severity information. Okay, so So we've said it's not a perforation. It can behave like a perforation. You see a very eccentric jet flowing the way this one did. If the history had suggested endocarditis, you'd be more worried about perforation. But in this case, you don't need to bring in perforation as a diagnosis. You can get the diagnosis just from flail. Okay, so procedure updates. So 3D imaging was used. We oriented the clip to grab, and generally the first clip action is to try to grab the area of interest. So we decided to go A2 and P3, because you have to get the area that's flailing, and you have to get the other side of it, which is something to grab the clip onto, and I'll show you that in a second. After crossing the valve, the orientation of the mitral clip is confirmed by reducing the gain. I'll show you that. So you can still see, because the device has a certain gain optimization, which is different from the gain optimization of the leaflets. So you take advantage of that gain differential by, once you've advanced the device past the leaflets, you can't see it if your gain is idealized for the leaflets, but you turn down the gain to see it. So here we go. So this is how we would orient the device. The flail is down here at P3. So your angle, you have to grab good tissue, which is A2, and you want to grab the pathology, which is P3. But once you cross the valve, there's cords, the device is open, there's cords banging it around, and if you're opening it and you cross it, it can be banged around and moved. So all of a sudden you had an orientation, and then you're in the ventricle with the device, and it's been rotated around, and you may not know that. So what you do is, as you cross the valve, you simply turn down the gain on the 3D, and that's all this image is. Now you can see that the device is now in the ventricle, and it has the exact same orientation. So this is a trick, is to take advantage of the differential gain of devices and native tissue to really identify where the device is within tissue. That make sense?
How do you guys determine what scalpel the anterior leaflet you're going to grab? Like why not go, the corresponding P1, A1?
Yeah, it's just a smaller target. You're trying to think through the biomechanics of how this leaflet's supposed to close and where you want to create the tissue bridge. It's very difficult to grab practically A1 and P3. A3 and P3. One of the other challenges is, if you remember the anatomy that we've talked about before, the more you get closer to the commissures, the more cords you're going to interact with. All right? Both commissures are a network of cords, just like a nest of cords running underneath them. A2, P2 is the cord-free zone, because the pap muscles come up, send their cords to medial and lateral commissures. So all the cords are clustered here. Right down the middle, there's no cords. So an A2, P2 grab is easy because there's nothing there to obstruct you. But once you start getting sideways, and the more you get into the corners, the more likely you are for your device to get tangled. Okay. So the imaging 3D was used to position the clip, and this is sort of one of the other tricks, and it's a sort of a technical trick, is you use a very small sector size, as small as you can, to increase both the temporal and spatial resolution. So this is the actual mitral clip grasping. This is typically what you try to do, is you want to image both of the arms of the device. This is the catheter that's guiding it, so it's still attached. You go down into the ventricle, and then under 2D guidance, you confirm several times using both 2D and 3D that the clip is in the right orientation, that you're exactly where you thought you are, that you're still positioned to grab A2, and in this case P3, and then you slowly retract the device until you've grabbed the leaflets. And this is an example. So the device is still open, it's still splayed like this with two arms, but now it's been pulled up against the leaflets, so you can see how they're closing on the device, with the anterior leaflet here and the posterior leaflet here. And then the next step would be to just close the device and create a tissue bridge. Okay, so after the deployment of a single mitral clip across the A2, P3 region, that was the target. The mean diastolic gradient was 2. The residual MR is significant, and I'll show you that. And what would be the next appropriate step? Okay, so this is the result of one clip. So it's kind of midline here, but you look over here, and we have a very little change in the color Doppler from what we started with. We still have a pretty significant vena contracta, a large jet. If you look at the VARC criteria or the Everest trials for mitral clip, the definition of a successful clip was 2+ MR or less. So moderate or less is considered, at least in the trials, a success. This is more than moderate, so this is not a success. Okay, but what do we do next? So this is kind of real time. This is how we use this data. Deploy a second clip across A2, P2. Deploy a second clip across A2, P3. and put the second clip lateral to the first one? Or do a second clip across A2, P3 and put the second clip medial to the first one? Or just stop and say you've reduced the MR and that's good enough. All right, so Clara represented well for the back row. We'll move up to the third row. This here, 6 potential voices. Mohammed made eye contact.
I would say 3.
Number 3, deploy a second clip across A2, P3, medial to clip number 1. Why medial?
Well, I mean, if you look at the 90 degrees PE, it almost looks like there's an eccentric jet that's erasing from the prolapse segment. So, well, actually, no, actually,
Uh-huh.
I'll take this back. Yeah, I'll take this back. I think it has to be more lateral.
Okay, let's look.
I mean, it's still prolapsing, so you haven't.
But the recursion jet is shooting.
It's still originating from that prolapse segment.
No, it's
Yeah.
shooting laterally. That's, shooting
So the defect, the origin of the defect, is this medial or lateral to the clip?
lateral.
So again, a landmark is important. In this view, this is your appendage, way over here. So if this is lateral, it's targeting lateral, so its origin is medial. So part of this, this adventure you're going across, you have to recognize quickly the anatomic landmarks to know medial from lateral. So when you're in a 4-chamber view, it's pretty easy. But once you start getting into 60-degree view and 90-degree view, recognizing medial from lateral can get more challenging. So in this case, it is. The residual, the dominant residual defect is medial to the clip still. Okay, so A2, P2, no, because that's not really the target. P2 is not the target, so that wouldn't really help very much. Lateral, no, and that's just because we just said the problem is medial. So we're going to target a second clip medial to the first clip. Okay, MR reduced, no, we still have a lot of MR by all criteria. And the important thing is the diastolic gradient's only 2. So you have lots of diastolic room to add another clip and make the orifice smaller. If the diastolic gradient was 6 at this point, there'd be a different conversation. It's much harder to know what the next step is. Okay, so this is the still image. So this is often what helps. This whole debate of medial versus lateral, this comes up in almost every case when you're considering a second clip. So this is where the 3D is helpful. So this is clip number 1, and we targeted appropriately A2 and P3. There's the clip. But if you look closely, medial to the clip, there's still, in systole, some prolapse. So we still have a prolapse target that we haven't achieved. So we kind of got some of P3, but not all of P3. Okay, so a second clip was deployed across A2, P3, medial to clip number 1. I'll show you that video. After implantation of 2 clips, all right, let me show you that. Okay, so this is kind of the same orientation with the aortic valve up here now. This is showing clip number 1. So clip number 1 is attached and it's deployed and it's actually poking down into the ventricle. That's the way the clip is supposed to be oriented. And then this is the second clip that's coming across to try to go into that medial hole. And then this is the deployment of the second clip. All right, so after implantation of 2 clips, the residual MR was mild. The mean diastolic gradient actually went down. So explain that. It was 2. We made the diastolic orifice smaller, and the gradient went down. How does that make sense? Good, echoing all the same answer. Very nice. So yes, so the gradient is flow dependent. And even sometimes, even if you make the hole smaller, the fact you're taking away the regurgitant flow, that then has to turn around and come back in diastole, that's how you actually reduce the gradient by making the hole smaller. A little counterintuitive, but it does make sense finally. So the final result, I'll show you that. And then bottom line, 6 months later, patient had an important clinical response. NYHA was improved and was moved out of his daughter's home and was living independently again. So this is the final 2 clips. That's pretty typical. That's a good ending for a mitral clip case, mild MR. And these are the 2 clips kind of shown here, poking down into the ventricle with these little 3 jets. So that's a pretty standard, mitral clip case. That's not the most extreme, but it's pretty representative. The messages from the 3D perspective are the orientation the inclusion of orienting anatomy, like the aortic valve and occasionally the left atrial appendage. You really need those to orient yourself. The thought process about medial from lateral and how do you differentiate that fairly quickly and in views other than the 4-chamber view. And then really the quantitation of the jets, both before and after clipping. Okay. This is kind of what it finally looked like. So now this is the beating view, and really there's a very tiny, 2 tiny orifices in diastole on the medial side, but it's really a dominant lateral orifice that you're left with. There's a still shot in diastole of the 2 tissue bridges. So effectively, we've really paralyzed P3. It's not doing anything now. And we probably got, in the second clip, a lot of A3, which is over here as well. But the mean gradient is down to 1, so that's a success. Questions? Yeah.
How often in clip cases do you need more than 1 clip?
About 50%. Yeah, it's about half. Yeah, we've done 3. We've done quite a few cases of 3. I don't think we've done any with 4 clips. By 4 clips, that'd be a big Barlow's case, and you're basically running out of diastolic gradient at that point. This is a 43-year-old presented with recurrent dyspnea for 3 years. He'd had endocarditis 10 years ago, surgical replacement of his native mitral valve at that time. Then he had a thrombosed valve 3 years after that with obstruction, had to get a redo mitral valve with another mechanical valve. So now he's on a second, he's had 2 surgeries, second valve in the mitral position. And then he comes back, he has this 3-year history of dyspnea. No fevers, no chills, no weight change, blood cultures are negative, white count is okay, mild anemia, normal retic count. He's referred for evaluation of mechanical valve function and to discuss the options. Okay, so these are the images. Again, this is mid-esophageal 4-chamber here, and this is a 3D HFAS. So, anybody, what are your thoughts on this case? Where's the problem? The problem is 1 o'clock. 1 o'clock on the 3D view. So your aortic valve is here, so you're saying here? Okay.
We don't see color. I mean, I don't have vision.
What's this? What's this?
It's better value.
Is this normal?
No.
This is abnormal. Is this transvalvular, paravalvular? Can you tell? Paravalvular? Okay. What about this one over here? Is that normal or abnormal?
I want to look at it better.
Okay. Washing jets are I don't know. Okay. But on this limited data set, this is probably the more dominant lesion is this thing over here. Does this spot on this view correspond to this spot? Are these 2 views of the same thing, or are these different things? So that's a very common question with structural intervention is you might see something and you see something in a different view, and is it the same thing? So let's go through this. Is this lateral or medial? How do you know it's medial? Because it's against the septum. What defines medial? The septum. So it's right up against the septum. I don't want to take the, I don't want to assume anything. I mean, we throw these terms around, but medial means septum. This is up against the septum, so it's medial. On this view, this is the septum. This is up against the septum. Okay. Now, this view can't really tell you if it's anterior or posterior. So this view doesn't tell you whether it's at 1 o'clock, 3 o'clock, or 5 o'clock. Could be any of them, but this view does. So, okay, so we have a putative lesion here at 1 o'clock with paravalvular leak. Okay. So the pathology demonstrated is most accurately described as, okay, we gave this away. Along the posterolateral aspect, no. Posterolateral would be on the clock face, more like 7 or 8 o'clock. You're all the way around at the back. Okay? Review. Posterolateral would be down here. This is anterior, this is posterior, this is medial, this is lateral. Posterolateral is back here. All right? The anteromedial. Yes? Medial and lateral. Okay? That'd be here and here. Is that possible? Not based on the data I showed you. I didn't show you anything that would suggest lateral. Okay? Extensive prosthetic mitral valve dehiscence.
No.
Why not?
It didn't look like it was.
Okay, so you moved your hands. Let's put that in words. How do we define dehiscence? What is dehiscent?
The rocking motion of the,
Okay.
of the valve.
So some demonstration that it's unsupported, that the prosthesis needs to be rocking. Is there a clock face extent that people recognize as representing dehiscence? 30%? 17? Any other numbers? 25? Quarter? Yes, that's a nice translation of 25. Okay, all right, so let's keep going. So,
I'm not being recorded by someone.
yeah, okay, you are actually. Posterolateral, for the reasons we said no. Congratulations to those who said antemedial, the answer is yes. Okay. Oh, this is a good point. So, potential paravalvular filling defect immediately to the right of the anterior hinge point. Okay, no, we'll come back to hinge points. Medial and lateral, no. So that was a washing jet. So we heard washing jets. The quick way to differentiate a washing jet from a paravalvular defect is what? Where do washing jets occur? At the hinge points. So if you know on 3D where the hinge points are, for example, in this view, 12 o'clock and 6 o'clock are the hinge points. So if you see small little jets at those points, that's just the valve opening and closing. Those are expected. You really don't get washing jets out here. So if you're looking at something at 9 o'clock or 3 o'clock, that's not going to be a washing jet. And that doesn't matter whether it's a transthoracic or TE. Those little jets should occur at the hinge points. Okay. Keep going. Washing jets. Okay, so 25%, and there's not a lot of data out there, but if you looked it up and you wanted to give it a number, dehiscence is the association of rocking, abnormal motion, and about a quarter, Mahawash likes to say quarter instead of 25%, of the circumference of the device. Okay. All right, so let's look at some color. So same orientation. I'm really kind of harping. You have to get comfortable putting the data in a way that everybody understands. So aortic valve at 12 o'clock. This is an element of very low frame rate, because sometimes when you're trying to capture with 3D with color, it's a lot to process. That's usually a big limitation, but in this case it didn't matter. You only need 2 frames. We have 1 systolic frame, but it's all you need. It clearly shows the surgical ring with these little bumps represent these single interrupted sutures. And this color is clearly outside the soul ring, so this is your PVL at exactly the 1 o'clock spot that we were concerned about. And you also see these little tiny jets at the hinge points. So those are normal washing. So all we did here was just took the data set, rotated it a little bit to sort of give you a different perspective of it, recognizing what we did and putting some labels so that you still know the aortic valve is here. And clearly outside the ring, little washing jets at the hinges. Any questions? Pardon me? They do not. They do not. So that's an important. So surgeons, there isn't really there's a preference. Some don't really acknowledge that it matters. There's a lot of variability on that orientation. It tends not to be 3 and 9. They tend not to go totally sideways, but there's all kinds of. You'd think it'd be much more standardized than it really is. So you can't assume 12 and 9 for the hinge point at all. You got to find the hinge points. Okay, good question. And in this case, it demonstrates that the frame rate is so low, but it still can be very useful. So don't give up on it just because the frame rate's low. All right, and this is actually a zoom down on the color. One of the challenges is to try to size a plugging device. What size device and how big is the hole? One of the ways to figure that out is to look at the effective area, which is basically the vena contracta, and that's just a zoom view, cone down. It's not perfect, but as an approximation for sizing a device, this one was 3 millimeters by 10 millimeters. So that's a starting point, at least, when you work with the device people and you want to stick a plug in there. Okay, so 3D color Doppler in the standard surgical view shows the PVL at 1 o'clock. Off axis is just another view of it. A still image was used to size, I showed you that. A device designed for occlusion of a PFO was chosen. So that's a little picture of the ADO2 it's called. PDA occluder is shown here. It's got these sort of 2 mushroom discs with a neck. Once you deploy it, it doesn't quite look like that. It tends to get more squished, but so when it comes out of the box, it looks like this. And this is how it goes in. So a transeptal. So again, same orientation. This is a guide catheter. It's already sort of stuck in the hole. This is a quick shot. It might take an hour to get to this point. If you're lucky, it takes 5 minutes. Usually if it takes 5 minutes, and about half an hour later, the wire will accidentally slip out, and the next time, it'll take an hour. But this is a wire went across, then the guide catheter sitting across the defect. So the guide catheter is across, a single device has already been deployed, and then a quick look with color, and it's kind of rocking, so you see the device kind of coming into view and then leaving again. So okay, so let's go to the actual question. Transeptal puncture was performed. 2 guide wires were positioned across the PVL site. Now you put 2 across in case you need 2 devices. You double wire it, because once you put a device there, it's very hard to get the second wire through. So you put 2 wires in, you put a device, and if it looks perfect, you just take out the other wire. So the idea is you double wire it, typically. So guide catheter is positioned over the guide wire. I showed you the PVL in that color. The ADO to occluder, so basically you deploy the device on the ventricular side first, you pull it back snug till it fits in the hole, then you deploy the atrial side, and now you've got both sort of caps deployed. So video 6, which is this one, so that's sort of the acute result. And the question is that good enough? Okay, that's the question. So it depicts the PVL immediately after deployment. The next step should be, okay, man, this one's for you. So do we implant a second occluder to address that residual PVL? Do we consider the procedure complete since we've reduced it to mild? Do we snare the device and remove it, saying total failure, device is no good? Or do we just kind of inspect the location and shape of the occluder thinking that we did something wrong and it just looks weird? Yeah, it's always the right choice. Yeah, take a closer look is always the right answer. But there was discussion initially of, you know, this isn't, we need a second clip, you know, this isn't working. So let's say that implant a second device immediately is the wrong answer. We're not done. There's too much residual. Snaring it's very hard to actually snare a device, and you don't need to, in fact, because it's, actually that was fully deployed. So you can get it out. We've done that. You can go actually and snare a device and pull it out. That adds at least an hour and some risk of embolic event. Inspect, yes. Okay, so here's the inspect.
So quick question, whenever you're doing those, once you deploy it, you really deploy it, you have to, right?
No, it's similar to MitraClip. You can deploy it while it's still attached, and you can get a sense while it's still attached.
But once you remove it,
Once it's deployed. Unlike a MitraClip, it's not actually fixed to the tissue with grippers. So in theory, you can go in and snare it and pull it out, but that risks actually enlarging the defect. If you're going to pull it through the hole you've just put it into, you can actually make the hole bigger. And if it's a little friable, you can make everything much worse. So this is the, I'm sorry, I misspoke. It is still attached to a, no, you're right, it's fully deployed. It's fully deployed. This is the second guide wire that's in there. So there's still a guide wire going beside it, but the first device is fully deployed. So we're looking at it here. There it is, and this image is rotated a little bit, so 12 o'clock is actually over here. Don't know why this is a video that doesn't play, but it comes, okay, here it comes in. So this was important. So this is why option 4 was the right answer to inspect. Because what had happened is, here's the guide wire, the second guide wire, and the first occluder. And I've never seen this until this case. The second guide wire had actually lifted up the edge of the occluder. So instead of laying flat, it was tented like this. So we recognized this with a 3D zoom and said, we don't need another device, just wiggle the wire. So Dr. Barker just wiggled the wire, it slipped around the side, the device fell flat, and that was it, that's all it needed. So sometimes your hardware, you know, can actually interfere with the device configuration and function. So that's it, we just repositioned the second guide wire, and this should be the final. So one plug here, obviously you're sizing it, and this is a bigger deal with the mechanical valve. What we didn't really talk about so far is you have to think about the shoulder of the device sitting across the annulus. Sitting on the annulus is not a big deal, but if it interferes with the leaflet closure, that's a big deal. We look at it from the atrial side, but really the concern is on the ventricular side. Because on the ventricular side, it's where it's got to close, and you can't really see it very well because the entire device is shadowed by the prosthesis itself. So you do have to do a lot of sort of functional evaluation. Is the gradient changed? Is the color? That kind of stuff. And this is the final, and you know, there's the device, and there's really no residual PVL. So this is a similar age, 46-year-old, refractory pulmonary edema, respiratory failure on a ventilator, end-stage renal for 8 years on hemodialysis. RV systolic dysfunction, clinical RV failure, non-compliance with his oral anticoagulation for a long time. So back when the surgery was done, which had only been 3 years before, sort of a controversial decision was they decided to put in a tissue valve in a guy in his 40s, largely based on a history of non-compliance with anticoagulation. So probably a recipe for disaster, dialysis, 40 years old with a biologic valve, but that's what he got somewhere else, thankfully. So he was worked up for bio-prosthetic mitral valve stenosis. We discussed him at our valve conference. Surgeon said, based on largely on the RV failure, he was really a prohibitive risk for redo surgery. So scheduled for a transapical valve in valve. And this I believe was our first transapical mitral valve in valve case. So these are kind of impressive videos, same orientation. You see the spontaneous contrast in his LA, the underfilled LV. And en face, it's fairly impressive. There's almost no visible orifice in diastole across this mitral valve. We did this to you, I'm not sure at this point how he was alive. So some functional evaluation, so some, that's what we do. So when you put color on, in fact, you see in diastole the blue. There is still some flow through here and a tiny, tiny bit of MR. And actually we can do a planimeter of the diastolic flow area. So it's an effective diastolic area, it's 0.75, remember? So in current guidelines, 1.5 is considered severe stenosis for native MR, or native mitral valve. And no question, under 1 is severe stenosis for any valve, including a bio-prosthetic valve. The mean gradient was 18 millimeters mercury, so super severe bio-prosthetic MS. So what were the options? So the findings is moderate bio-prosthetic valve stenosis, I just said no. Moderate bio-prosthetic regurgitation, I said no, it was very mild actually. Moderate stenosis with moderate paravalvular, no. Although we do see that quite a lot actually. So he's number 4, severe bio-prosthetic stenosis. We're at Doppler gradient is over 10, valve area is less than 1.5. Those are the numbers for severe stenosis. Okay, these are the explanations we just went through. Okay, so the procedural detail was a transapical approach. The plan was to put in a 26 millimeter Sapien XT valve. So this was sort of a first generation valve that we would use for TAVI across a native aortic stenosis, but in this case we're putting it across a mitral valve. This is the intraprocedural, so there's a wire coming up through his LV apex. This is the guide wire. It's come across the valve, so the wire is from the LV apex into the LA. And then this is sort of an intraprocedural shot of the Sapien valve being deployed. There's a cath shot, transapical catheter into the surgical valve. So here's the tricky question. So you're pretty technical, but let's just talk through the principle. So you're deploying a Sapien valve within a bioprosthetic mitral valve. Sapien valve is balloon expandable, so you've only got one shot. You can't half deploy it, move it around. You got to put it, fire it, and then you're done. Wherever it lands is where it lands. So you have to think ahead of time, where do you want to land it? You want it to be 20% in the atria, 50 and 80% in the ventricle. So ventricular preference. Do you want the opposite? Or sorry, do you want it 50-50, where it's half in the atria, half in the ventricle? 80% in the atria and only 20% in the ventricle? Or it really varies depending on the aortic mitral angle. So, okay. So Cassie thinks she's taking the safe one based on the last case. Option 4 varies. In this case, that is incorrect. So you're saying mostly atria?
No.
I'm sorry. You're saying, 80% ventricle. Okay. That's one option. 50-50 I heard over here. Well, let's go show of hands. I'm confused. Number 1. Okay, we got a couple. We got 3 for 1. Number 2. Okay, smattering. 3. Well, that's the winner so far. 3. And with the Mawash cop-out. Number 4. I already said it was 1, but she's sticking to her guns. I like that. Still wrong. We will. So the one problem. So number 1, if you go 80% in the ventricle, that's a big bulky device. You're putting a big bulky Sapien inside what's already a fairly bulky prosthetic valve. There's a real concern for LVOT obstruction. Because if you're 80% in the ventricle, you're actually going to be lower than the struts of the surgical valve. So LVOT obstruction is the main concern there. So it's not 80. 50-50 is really what what's recommended. With the caveat though, you put it roughly 50-50, but then you do kind of a weird thing with the balloon. You preferentially flare the ventricular side. Because what you want to do is you don't want it to be sitting perfectly the way it would in the aorta. You want to flare within the ventricle so that the ventricular pressure acts like a cork. If anything, it'll push it into the surgical valve. If it's like this, the theory is you can actually eject into the LA. It may not be right away, maybe a month later, but that's a disaster. So any valve-in-valve mitral, there's an element of flaring on the ventricular side. And that you can do if you go 50-50. And that's the problem. If you only went 20% ventricle, the concern would be you wouldn't have enough purchase to prevent being shot into the LA. All right. And then the Cassie approach, generally, yeah. I mean, the aortic mitral angle is very important. But in this case, the native, because it's a surgical valve, the native anterior leaflet has already been removed by the surgeon. So you're not as concerned about the aortic mitral angle because you don't have a native anterior leaflet that you're going to force into the LVOT. When we're doing transcatheter mitral valve replacements, de novo, into a native valve, the aortic mitral angle is very important. So basically, the older you are and the more crunched and elongated your aorta, the more this happens. If this is your mitral and this is your aortic, planar is perfect. There's no risk. And then you get a little old LV with an enlarged aorta, this starts to happen. And the closer you get to 90, now you're going to stick a Coke can right here, and you're going to obstruct the LVOT. So that's the aortic mitral angle. It's very important, but typically not for this because they have no native anterior leaflet. Okay. And these are this is the immediate post. So this is a sapien deployed within the surgical valve. Diastolic area, remember, was 0.75. Now by color at least 2.3. And the median gradient went from, I think it was 18 down to 3. But we're not done. You have to sort of evaluate the function of this new procedure, of this new valve. So you want to see unrestricted leaflet motion. So this is now the sapien inside the surgical ring. 2 different views, good coaptation, no perivalvular leak, and no central leak. And you can get any of that. If the new valve doesn't really conform to a circle, you get malcoaptation in the middle, and you can get a central MR. Any questions about that? Okay, so sapien XT successfully deployed. Target depth was 50-50. I think it ended up being 40-60 with a little bit of ventricular preference, but that's what happens when you sort of put it, a single shot balloon expandable valve. You don't always land exactly where you want. Mean diastolic gradient was 3, extubated and discharged. And this is after sort of weeks in hospital and a lot of time on a ventilator. He did very well.
Does the surgical valve, do those leaflets get pushed into the atrium, or do those fall, or do they?
Just like a TAVR, they just get pushed to the side. Okay. So they now sit. No. They just get crushed against the set. So the valve is upside down, right? The flow is going down. Yeah. So the leaflets are opening down. Yeah. Leaflets always open into the 3 struts. Yeah. So there's a potential, so now they're just forced open within the struts. But even those, the leaflets on a bio-prosthetic valve are still not as bulky as a native anterior leaflet would be. And they can't get pushed past the struts. Right? The struts are going to prevent the native leaflets from getting pushed into the LVOT. As long as the strut's not in the LVOT, then the leaflets also can't get into the LVOT because they're nice and contained by the struts. Okay? That's probably all I'll go through today. Any questions about that? So let's look at this DVD. We can do this again on a different venue if you want. There's like 50 cases or 40 cases on this DVD. All kinds of different stuff. All right.
General question.
Yeah.
This is amazing work that you and Dr. Barker and team. How evident is this work in other sites, other places? What do you guys do here? The interventional part.
I mean, there are other sites that do the same.
Common, like not in the US?
No. Well, I mean, there's select sites. It's not common.
The last case was like amazing. It seems like not surgical, all this stuff. If he's gone somewhere else, probably you wouldn't have received what
You're right.
he
So.
here.
So actually, the ACC has created a writing group, and I'm on it, and it's to create definitions for comprehensive valve centers and regional valve centers to try to define who does what's the expectation of a patient who's seeking care and referring docs, and it's kind of for the first time laying out, what's expected of a, how this trauma centers level 1, 2, 3, 4. This I would consider us the equivalent to a level 4 trauma center for valve. But there's all kinds of other levels. So societies are trying to put that together and try to define what that's level 1 trauma, yes, which we are not. We're a level 1 valve, not level 1 trauma. Yeah. Yeah. So yeah, it's around in Houston. There's 3 sites who would do this, but in fact, Herman and Luke's, they really don't do perivalvular leak, and they have, and as far as I know, they have a very, very small MitraClip program, and they might do 5 a year. But I think Eleanor, how many MitraClips are we at now for the 2-year experience? 70? 78. So I think we have the biggest MitraClip experience in Texas. There's a couple of centers in Dallas. They started long before us, but their annual volume is much less than us. All right, thanks, guys.